Good evening, everyone. Welcome to our Health First webinar series community health event brought to you by Alpha Kappa Alpha Sorority Incorporated, the North Atlantic region, brought to you by our esteemed Regional Director, Alicia Pagee Spearman. My name is Dr. Benita Coe. I am the North Atlantic Region Chief Medical Officer. I'm a member of Alpha Kappa Alpha Sorority Incorporated. I am also an internal medicine physician and I'm an author. I wrote a book, How to Help Your Doctor Help You. And I am so glad that you have all joined us today as we do talk about this important topic, prostate cancer screening, what we all need to know. So, thank you for joining us. Our program this evening will be a conversation between our two guest experts. And we are going to have a robust conversation after I introduce our guest experts and have an introduction by our sponsor from Zero Prostate Cancer. And then we are going to jump into our discussion and we're going to save plenty of time at the end for all of your questions. So I will begin by introducing our first guest, Dr. Doris Brown. Dr. Brown is president and CEO of Brown and Associates LLC, a health consulting company that manages programs addressing national and global health inequities. She is a medical oncologist and the 118th president of the National Medical Association, and she is a retired colonel of the U.S. Army Medical Corps. She tirelessly champions many causes that significantly contributes to the health of people of color with a keen sense of urgency in creating a culture of health equity. Dr. Brown is also retired from the NIH National Cancer Institute, where she managed the breast cancer portfolio in the Division of Cancer Prevention. She chairs the NMA Project Impact 2.0, where she advocates for increasing minority participation in clinical trials at all levels of clinical research. She is a graduate of Tougaloo College, where she received her Bachelor of Science, received her MPH from University of California at Los Angeles and her medical degree from Georgetown University. She is a member of numerous professional organizations, and she is also a member of Alpha Kappa Alpha Sorority Incorporated. She is also, as I mentioned before, the 118th president of the National Medical Association. Our next wonderful guest that we are so happy to have him here is Dr. Kirtland DeVille, who is an associate professor in the Department of Radiation Oncology and Molecular Radiation Sciences at Johns Hopkins University School of Medicine in Baltimore, Maryland. He serves as medical director of the Johns Hopkins Proton Therapy Center and clinical director and chair of Sibley Radiation Oncology. Dr. DeVille's clinical expertise involves treating patients with prostate cancer. His funded research interests includes improving tumor targeting and assessing target toxicity profiles using modern radiation techniques, including proton therapy. He received his medical degree from the Warren Alpert Medical School of Brown University, and he did his residency in radiation oncology at the University of Pennsylvania. So, welcome to both of our guests. And now I am going to introduce our guest from Zero Prostate Cancer, Brian Bragg, who is the Chief Mission Officer, who will give some brief remarks and with a few slides to talk about his organization. And because he is a sponsor, a welcome sponsor to our program. He has more than 2 decades of leadership experience in public health, health promotion, and health systems integration. As Chief Missions Officer at Zero, did I see? I might have said Chief Medical Officer earlier. Sorry. Brian oversees the development and execution of community informed, equity driven strategies aimed at increasing awareness and early detection, eliminating stigma and barriers to care, and improving the lives of those disproportionately impacted by prostate cancer. So, welcome, Brian Bragg, as thank you for giving brief remarks and telling us about Zero Prostate Cancer and your organization. And thank you for being a sponsor for our program.
Thank you, Dr. Coe. It's an honor and a pleasure to be here this evening for this very important conversation to be had later on. So as mentioned, I'm Brian Bragg. I am the Chief Mission Officer at Zero Prostate Cancer. Zero is the largest patient advocacy organization focused on prostate cancer in the country. Our mission is to improve and save lives from prostate cancer through advocacy, awareness, education, and support. We started our journey 30 years ago as an advocacy organization, and we are responsible for over $1 billion in prostate cancer research funding since, which is housed at the Prostate Cancer Research Program at the DoD. We offer and provide education and programmatic supports for those living with the diagnoses and their caregivers and care partners or loved ones that make up their support network. I'm really happy to talk a little bit about and introduce to this audience our Blitz the Barriers initiative, which was introduced earlier in the year. This is the largest investment in public health initiatives in prostate cancer ever. It is a 3-year, $20 million initiative to help educate, provide greater awareness in 12 communities that have had the highest disparity rates when it comes to screenings, initiation, and engagement into treatment, and quality of life and mortality outcomes. With this initiative, starting in Baltimore and in Atlanta, we aim to be really ambitious to serve over 500,000 people through educational programs and elevate and change the conversation about prostate cancer messaging and awareness to reach over 25 million people through media impressions. We'll start again in our 2 pilot communities of Baltimore and Atlanta, and we are looking for volunteer partners at the national and local levels to help activate volunteers to engage with health fairs, support and amplify screenings, and to make sure that everyone at risk is touched with education and has the opportunity to get screened in the communities where they live. So we have this initial initiative approaches that you see here. The next slide, please. We're also initiating a patient navigation pilot service, which will provide clinically licensed patient navigators and practices in community, a virtual navigation pathway, and training specific volunteers to provide peer-led or volunteer-led patient navigation in the communities, along with some other supportive modalities to make sure that those living with the diagnoses, whether early stage or advanced stage disease, and those who love them are able to access resources and support via support groups, mentors, or any materials, how to help to support a conversation with their provider teams, making sure that in the communities that we are serving, we decrease these disparities and help improve quality of life. Final slide, because I want to make sure you all get to your robust conversation. Here are the community areas where we are endeavoring to serve. And this is based on data that speaks to the high rates, disparity rates, again, for screenings, initiation and engagement to treatment and mortality. So we're starting off in Baltimore and in Atlanta. You may have seen some elements of our media launch in Atlanta with Montel Jordan, Dr. Matthew Knowles, otherwise known as Beyonce's father, and Alan Houston and his father, both of whom are on their prostate cancer journey. Phase 2 involves Detroit, Washington, New Orleans, and Mississippi. And then phase 3, the communities of Houston, Chicago, Alabama, Appalachia, and then South Georgia and other rural parts of the state of Georgia. So it is an ambitious initiative, which we will begin over the next 3 years. And then based on what we learn, scale and replicate where we are able across the country. Happy to be here for part of this conversation. Happy to be a partner and join with Alpha Kappa Alpha Sorority Incorporated, as a sponsor and as a partner, and helping to elevate those of you who may be care partners living with someone and caring for someone that's on a prostate cancer journey. proud to be here. And then I give the floor back to continue on your conversation.
All right. Thank you very much, Brian Bragg, for those comments and introducing us to zero prostate cancer. All of the slides in the deck will be sent to all of our guest participants in the webinar after the webinar later on this evening or tomorrow morning. And just as a part of the webinar, I always like to give a disclosure to make sure that you understand the information that we're providing today is not to replace any recommendations made by your healthcare providers. And please consult your own medical professionals before initiating any medical changes in your care. And also, please make sure that, and I will be putting the link also in the chat, but here is our QR code for our program evaluation. It is very helpful to complete the program evaluation and let us know what you think about the program that we are putting on today. And also, this slide will also be in the deck for you to look at later. I actually do a monthly health newsletter, and I actually did a newsletter, which you can see on my website, that's called Let's Talk About Prostate Cancer Screening. And so let's jump into our program, and starting with just some images and graphics just to level set about where is the prostate gland. So this is a picture of where the prostate gland is. It is a gland in between where the bladder is, and it is just, these are pictures to just give you an idea, just graphically, where the prostate gland is in the gland that we are going to be talking about today. And the next slide just is a summary, which you can read later, but just a summary about what the prostate gland does. It's an organ in biological males located under the bladder. It produces fluid and that gets added to semen. It also has muscles that helps push fluid through the urethra during ejaculation, contributes fluid to the semen. And I use the word ejaculate, and I define that there as a whitish gray fluid that releases from the penis with orgasm. And that fluid has a lot of good things in it: enzymes, zinc, citric acid, which helps nourish sperm cells and lubricate the urethra. And the urethra, by definition, as well, is that tube through which the ejaculate comes through and urine to flow out of the body through the penis. So we are talking about intimate parts of the body, and we're using the medical terms that describe what we are talking about today. So let's jump into the questions that and start our conversation that we are having with our guest today. So the first question to ask our guest today, starting with Dr. Brown, what is prostate cancer and where does it come from? Dr. Brown?
Yes, excuse me, I was muted, but thank you so much for that question. And thank everyone for joining us this evening. And it is so important for us to talk about prostate cancer. It is certainly, in terms of cancer cases, the largest number for men or males happens in prostate cancer is number one, yet the one that causes death is not prostate cancer. It's usually lung cancer being the cancer that kills more men and women in this country than any other cancer, even though men tend to get prostate cancer more. And prostate cancer is an abnormal growth of the cells in the prostate gland. And you have shown where the gland is located under the bladder. And when there is a turnover of those cells, it tends to grow very large it can be contained within the gland, but it can spread to areas that are around it, or what we call metastasizing, spreading throughout the body. And you will hear about that in our discussion. So we would love to know what causes it, but there are several things that's listed in terms of risk factors, but we have not gotten that Nobel Prize of knowing what causes cancer. Certainly it is related to inflammation, and that is a overall term, but there's nothing known specifically about what causes those cells to start to grow.
Thank you, Dr. Brown, for answering that question. It is always sometimes unsettling when we cannot give a definitive answer with that type of question. And Dr. DeVille, the next question goes to you because with many cancers, including prostate cancer, knowing family history becomes a very important part of determining what someone's risk is for prostate cancer. Can you tell us why knowing family history is so important in evaluating someone's risk for prostate cancer?
Yeah, happy to answer, and thanks also for the invitation to be with you all this evening. So family history is important. As Dr. Brown mentioned, we don't quite know the cause for prostate cancer, but we do know a lot of risk factors and associations. And so family history falls into one of those categories. And usually I tell men, basically, if you have a first degree male relative, so father, brother, son, if one is diagnosed, the other is at much higher risk for being diagnosed. And then we can also think about, genetic kind of history and risk factors. So although kind of true familial genetic, prostate cancer that's running in families, although that sort of rate is quite low, there are some genes that we do know are associated with higher rates of prostate cancer, such as the breast cancer gene, which can be associated with prostate cancer in men. And there are other known genetic mutations, though we don't hear about them as much. There are others that are associated with prostate cancer. And so it's important for everyone to kind of know, and I know perhaps our families don't talk about as much, what if there is any history of cancer in any relative and any family members, and kind of have where we do a family tree, but knowing your sort of cancer family tree can be important to try to tease out when you see a physician, are there sort of any obvious patterns or risk factors that might, bring associations for prostate cancer or any other cancer, frankly, as you're kind of seeing a primary care doctor at the point of deciding what screening and things should be done. So, all that to say is there is some associations with prostate cancer running in families. And so it's important to know, especially for men, if they do have a history of prostate cancer in their family. And then when we start to talk about screening, that also defines that technically they're not kind of normal risk, actually at higher risk. And that should be one of the reasons that they should undergo screening for prostate cancer.
All right. Thank you, Dr. DeVille, for explaining that to us. I know that it is sometimes very hard to get family members to even talk about what conditions that they have, but it's very important to try and elicit that kind of information. And then for the next question, for both of you to have a discussion to talk about the stigma of prostate cancer uh, screening, and talk about for both of you, talk about your experiences that you see with patients and the stigma of talking about prostate cancer and prostate cancer screening and the diagnosis of prostate cancer with African American men not wanting to get screened or not talking about if they are diagnosed with prostate cancer. As we put up slide number 20 that I made, that I gathered in my experience about sometimes why people decline getting screened.
Well, since I'll start with this in terms of how important it is for screening, very important, because you can detect that prostate cancer early. That means that your treatment is likely to extend your life and not have it metastasize to other parts of the body. So the fear and the stigma, because this is sort of a sexual related disease. And so, well, in general, African American men really don't want to go to the doctor very often. They want to put things off. That's not a macho thing to go and get screened. And there's several screening tests that are very effective. One is a blood test called the prostate specific antigen, which is a protein that you can get that blood test, and there's a range that's there. And I'll let Dr. DeVille speak about what is normal and what is abnormal, and what happens when that test starts to grow. You also can do part of your physical exam. The doctor will give you a rectal exam by sticking his finger in your rectum and feeling the prostate gland. And so if it feels like it is large, abnormally not as round and smooth as it normally is. And so those are signs that you really want to get that screening. And again, there are other tests that can be done, but those two are really very important. And again, you've indicated there where there's a great deal of fear. And certainly when I was seeing patients, they would say, oh, no, they don't want to get that rectal exam. Usually it's done by the urologist, but other primary care physicians can do it. And they'll say, that large hand, that big finger, oh, no, I'm not getting that. But again, we need to overcome that fear and get that exam. And I would usually say, well, as a female, my finger is not quite as large as the male, but you still have to have that digital rectal exam. And you should get the blood test before you manipulate the rectum, because again, that may cause the protein antigen to increase. So Dr. DeVille, would you like to add to that?
Yeah, definitely. I'll add to that. And I think, a lot of the things being displayed on the screen are very common in terms of the barriers that we hear men expressing. But I think in general, yeah, there is sort of a stigma associated with, the prostate, and talking about men's health and sexual health, and, the things that um, tests and treatments that we apply in this scenario, impact those things. And so there's sort of just discomfort with talking about that or even acknowledging it. And I often say, I think for women, we've done a good job in talking about, sort of removing or trying to reduce that stigma. We talk about breast cancer and mammograms, and we talk about pap smears, and reducing risk for cervical cancer, and all of these are sort of normal, sort of very much normalized. And for men, there are, those conversations are not considered normal in talking about your health, and are you keeping up to date with your health screenings and those sorts of things. And I do hear there's sort of, so I think one, having these conversations is important, as much as we can support the men in our lives, with that conversation, and providing this sort of safe space, and encouraging them to do that, and just asking, did you have a physical? Is your doctor, do you know if they're checking for prostate cancer? And usually I tell men, don't let you hear about, one, the blood test, which we talked about. It's pretty easy to get a blood test, right? But the digital rectal, often there's this sort of fear of like, oh, they're gonna, stick their finger in my rectum and feel for the prostate, or check the prostate, and many other things you're sort of checking for while you're doing that. Not just the prostate, you can check for blood and, other things. But what I usually say is, to men, is don't let that fear be the barrier, to the visit or to the exam. You can decline it. You don't have to have a digital rectal exam. We have now better tools, imaging, and things that we can apply to help us detect and diagnose prostate cancer. But I know, from what I've heard, there's so much fear in that's stopping them from even going to the doctor in the first place. And so, you're not even, let alone cancer screening, they're not getting blood pressure and cholesterol and, all the other things that should be checked through a primary care visit. They're sort of missing out on, just because of this fear of that happening. So one, I think, as much as we can do to reduce and eliminate that's the stigma for men, encouraging them to talk, and guys to just sort of talk to each other. And then, having a conversation, sort of empowering men to have conversations with their provider, comfort level with their physicians. We know there's a long history of, distrust and lack of trustworthiness, in medicine, that that side of things has also not done well, and so it is tough. It's we can't all just blame Black men for the situation that we're in, but at the same time, it is our health, and we need to be advocates for our own health. And so, kind of speaking up, asking questions, and trying to have a comfort level with your physician, I think, is step one, so that then you can gain the benefit from all the things that are going to come after, including the discussions around screening for prostate cancer.
Okay, thank you for getting through that, and hopefully that will help the men in our audience, and also the women in our audience, help the men in their lives get through that barrier if they are fearful of getting started with prostate cancer screening. And now, Dr. DeVille, the next slides 21 through 30 are for you as I ask you this question and ask your expertise on the slides that you have given to us about why do African American men have a higher incidence of prostate cancer and a higher death rate from prostate cancer, and how common is prostate cancer in African American men? Because this kind of information is important for men to know, to let them know how important this condition is in our community.
Yeah, definitely. So I can walk through this a little bit, and Dr. Brown set the stage in giving us some of those statistics around cancer in general. So these are statistics from the American Cancer Society. So in the United States, prostate cancer is the most common cancer in men. In terms of incidence, breast cancer in women, lung is second, and when we look at the death rate, that number is reversed. There is more death related to lung cancer. But prostate cancer is still the second, number two cancer killer for men in the US. So still very important, though we can have very good outcomes. There is still a risk for death. And that is kind of the big underlying piece here. And though we hear prostate cancer may be indolent, less aggressive than other cancers, there are still lethal and deadly prostate cancer. And those are the ones we want to, in particular, make sure we're not missing when we're screening and diagnosing and treating and going through that continuum for men. So we can go to the next slide. So just some key statistics. So almost 300,000 cases per year in the US, 1.4 million globally, and really increasing global incidence, because there are many places in the world that don't actually do routine screening. So that it's really kind of an underestimate of the incidence. So about 33,000 deaths in the US each year, and 375,000 globally. It is a cancer of older age. And so, about 60% of men are over the age of 65, when diagnosed, and it's pretty rare under the age of 40, although I do certainly see men in my practice who are in their early 40s and being diagnosed with prostate cancer. As I mentioned before, we don't know what causes prostate cancer, but we do know risk factors and associations. So age being one, it's occurring in older men. West African ancestry in particular has a highest rates of all ethnic backgrounds globally. And so that's why in particular in the US, we see high rates among Black men. Family history we talked about, and inherited genetic conditions such as the breast cancer gene, the BRCA genes, and Lynch syndrome, P53, and others. Um, and so the familial predisposition, like I mentioned, is a smaller percentage. Only about 5 to 10% of men diagnosed with prostate cancer is actually a sort of true known familial predisposition. And then regarding smoking and excess body weight, we know that they don't cause prostate cancer, but they definitely increase the rate of fatal prostate cancer, so death from prostate cancer if men are diagnosed with it. So it's important to talk about smoking and diet and exercise and those sorts of things in this context. It still becomes important. Smoking cessation. Next slide. So talk through some of that. Is the second leading cause of death. The good news, most men that are diagnosed with prostate cancer do not die from it. And so there are, more than 3 million men living in the US who have been diagnosed with prostate cancer at some point and are still living. 90% are diagnosed at the local, or what we call regional stage, where it's not progressed more distantly. And so the 5-year survival for those men is greater than 99%. But when we look at those who have a metastasis or distant spread beyond the prostate, which for prostate tends to go to bone or lymph node before it goes anywhere else, that 5-year survival drops, significantly and is only 34%. So that's why I was talking about that big difference and where we don't want to sort of let the cancer get too far ahead where we've missed that opportunity for our higher rates of cure. Next slide. I mentioned some about the global burden. You can see that the incidence is higher in high income countries. And that's really due through screening and testing and those sorts of things. On the other hand, the morbidity, sort of the mortality and disability adjusted life years are much higher in regions like Sub-Saharan Africa, West Africa, and Caribbean, where rates are rising and, often diagnosis is quite late. And access to care and effective care is limited. So really a global problem. When we hone in on more in terms of disparities and specifically African Americans in the US, so the American Cancer Society has this broken down by different demographics. You can see for Black men specifically, the incidence there, how many cases per year. There's just under around 30,000 per year in the US. When we talk about the disparity or the risk of dying, so the risk of developing prostate cancer on the left, the bottom there shows it's actually about 1 in 6 for Black men, even though it's only 1 in 8 for white men. But the death rate is twice that of white men. And so 1 in 23 will die of prostate cancer, whereas only 1 in 42 white men would die of prostate cancer. And so really, as we'll talk about this is really, although we have an increased incidence, we shouldn't be having a higher, it doesn't mean we should have a higher death rate. And most of the studies find that the risks related to the higher death rate tend to do with disparities in access to care and not accessing high quality equal treatments. And when men are actually in those controlled environment, Black men, for example, in clinical trials, much of the data shows their outcomes are just as good as white men. So I think that's a sort of key theme that I usually want to make sure people are aware of. Don't think just because Black men have a higher incidence of prostate cancer that their outcomes need to be any worse. They should be just as good if they're getting the right care, access to timely, high quality care, that their outcomes can be just as good. And so, yeah, this is just looking at, there are disparities across other cancers. And you can see prostate is at the top on the worst, and on the left shows for men and the right shows for women. Multiple myeloma, though is not the topic of conversation today, is another cancer site where we see, high disparities in terms of outcomes. And so it's just important to have an awareness. And so that we can, again, be our best advocates if we're, working with family members or others, our communities, and ensuring that we're not perpetuating these disparities. This is another statistic. So I mentioned the incidence in the US when we think about 30,000 per year. What that really translates to, and this is a graphic I like to use actually from my colleagues from the Zero group, that translates to a Black man being diagnosed every 13 minutes. In the US, there's a Black man diagnosed with prostate cancer and dying every 87 minutes. So if it makes it easier, I say like kind of every 15 minutes and every hour and a half, there's one dying. So I don't think people quite, realize that it is such an issue and it's such an impact. But often when I see and talk to some of my patients, when men are being diagnosed with prostate cancer, when they do start to talk to their friends and colleagues and neighbors, they start to realize actually how many of them are suffering from the same thing, have gone through treatments, or going through treatments, had a diagnosis, or going through screening and testing and working. And so I think that's where, again, if we can, encourage those conversations, we'll realize that there's actually a lot of people going through this, and there's a lot more impact that we can probably have. This just shows, sort of just driving home the points. When you look at the curves of different demographics there, the red line is Black, African American. So in both our over time, our incidence is gone increased, and by age, there's sort of an age distribution difference there as well. Again, it's a disease of older men, and that mortality rate is worse again for Black men. I've talked a little bit about this. So again, though the incidence is higher, the death rate does not need to be worse. What we really see are that there are disparities or inequities, just people not accessing the healthcare system or having the same level of quality of care really along the entire continuum of, so from what the patient might experience from the initial point of screening. Are they even getting the test offered to them? Is the physician counseling them on the risks and benefits and pursuing the blood test? After that, are they having, high quality diagnostic workup? Is the same, are they being offered a biopsy? What type of biopsy and approach are they being offered? Imaging studies, we see disparities on what types of imaging scans Black men tend to get versus white men, or be, at less likely to get the same guideline concordant care, basically care that's following guidelines. Whether they're getting even treatment, offered to them, or there are delays in care, or the types of treatments that they might get may not be, again, the same. And I mentioned a little bit about this, though, that when we have very controlled environments like a clinical trial, as was mentioned earlier, patients on studies, they have very rigorous, time points. Everything needs to be very well documented. They have coordinators and navigators and people kind of chasing things down. And we see that the outcomes for patients for Black men are just as good. When we've looked nationally at radiation oncology trials, it's been shown for chemotherapy trials that Black men, and some are even actually doing better than their white counterparts in some of these analyses. And so that we can really equalize care in those settings. And really should be the real world, scenario as well. This framework is borrowed. There's a really, for those who are really interested, in the New England Journal of Evidence journal, last year was published for the first time. Actually, Prostate Cancer Foundation supported this with guidelines for Black men for screening. And they provided this framework. If we think about, we don't really know why Black men have higher rates of prostate cancer. We know that there are sort of there are ancestral factors, right? Those genetic predispositions that I mentioned, being of West African descent. But why, when you come to the United States, you have the highest incidence in the world? There must be some dietary, environmental, other factors within the environment that contribute to that, to both the incidence, and then also, again, why the disparities manifest in interacting with health system, and all of those factors that are sort of noted there that can ultimately influence why we have both higher incidence and also death rate. Okay.
Okay, so thank you for going through that. I thought that was important for people to understand about how important this condition is for us and our community. And then knowing all that information, the next question that many people may have is, knowing all of this, what are the risk factors for even getting prostate cancer? And knowing all this information, what can men do to prevent prostate cancer, and what can we do in our lives to decrease the risk and prevent prostate cancer? For both of you, can you discuss that for us? As I did put a list of things on the slide here that people that we have been found has been found to make an impact on decreasing cancer in general, but also decreasing prostate cancer risk.
That is very true. And I like to say that there are modifiable risk factors, and those are things that's really related to lifestyle. Smoking, drinking, eating foods that are not as healthy for us as others, and controlling our sugar, our blood pressure, and our cholesterol. So these are things that we can control in a sense, or you can at least modify that if you decide that I want to lower my risk. And then, of course, those genetic things that you've heard about, that's part of the family, you really can't change those, but you know that it's there. Then the screening will put you on alert to maybe start your screening a little bit earlier, so that you'll know when things change. And getting the tests that we talked about as part of the screening is going to be important. But again, we know that fat in our diet is not good. We know that eating heavily processed foods are not good. And then there are some environmental factors that we have not yet come to grips with, but environmental factors are very important, that we look at and minimize our exposures to those toxins in the environment, and whether they certainly if you look at multiple myeloma, some of the other diseases where pesticides and those kinds of things that we are exposed to in our environment, fossil fuels and exhausts from cars, etc., that we need to be very careful about in our exposure. And then you want to, as I say, get a healthy diet, things that maybe leading to ketosis, so ketones and things that are high in that polyphenol area in terms of what we put in our diet. And then doing a regular exercise. And it doesn't have to be every day, but getting a routine that is going to be effective for you. And then what we don't talk about, and we know being Black in America is stressful, that leads to an increase in our blood pressure and all of those things. But again, that impacts our cancer risk as well.
Yeah, if I can just add and just to build off of that and highlight in particular for prostate cancer, we hear about trying to reduce the amount of meat, red meat, and having higher amounts of, plant-based diet. I've been telling patients, the good news, there's some data study that came out within the past year or two showing that it's not an all or none thing, that, when you increase the amount of plants, fruits and vegetables within your diet and decreasing meat, every little bit helps. And so you sort of can continuously reduce the risk for prostate cancer, of getting prostate cancer or having a recurrence of prostate cancer. And just, historically, the diet that we had in the US, that's high in saturated fat and red meat, has not served us well in terms of our risk for prostate cancer in men and breast cancer in women. And we hear a lot about the Mediterranean diet, so plant-based diet, but also Mediterranean diet that's sort of lean, uses very little meat or lean meats and fish. For prostate, tomato, products are healthy. Cruciferous vegetables, I know some of that is listed there on the screen. And so these are the type of things that we do counsel patients. High levels of exercise. There was a study that had come out that showed actually increased levels. We used to say 90 minutes per week, which kind of comes out to 30 minutes 3 times a week. But show that you did 150 minutes, so maybe 30 minutes 5 times a week, or some people like to do the big chunks or hike or some bike or something on the weekend. But if you got that higher intensity, those patients had a less risk for prostate cancer recurrence. So it's maybe nothing sort of so surprising, but these real things really do make a difference, really do matter, and can encourage people if they want to reduce their risk for prostate cancer. And even once they have it, it's still reducing their risk for progression and recurrence.
So, having all of that information, um, how does one know if you even have prostate cancer? So, what are the symptoms of prostate cancer? And if I'm walking around living my life, how, Dr. DeVille, how would I even know if I have prostate cancer?
Well, one of the things I like to tell men and usually say, if we waited for symptoms from prostate cancer, we've waited too long. So you really should not be having any symptoms from prostate cancer if we're doing our screening and monitoring and following closely. And that's really how most men in the US, fortunately, are diagnosed through screening, when the cancer is detected very early before it rises to the level of having symptoms. I'm generally saying for cancer, we always want to stay ahead of the cancer. If you're trying to catch up to it, usually your outcomes and things are not going to be that good. However, nonetheless, and then particularly in the era before we had PSA, this is how men would present, and still may present if they're not getting a PSA done regularly, and so the blood tests done regularly. And so because of where the prostate's located, as we heard in the beginning, it's basically surrounding your urethra, the tube that's draining the bladder of the urine. And if it starts to sort of compress or irritate or obstruct, they may have trouble with urination. More commonly, the prostate for men is just enlarging as we age, sort of called benign prostate hypertrophy or sort of benign prostate enlargement. And so, we sort of caution men, don't get worried or sort of assume just because you're having urinary symptoms that you have prostate cancer all of a sudden. It is a reason to see your primary care doctor, see a urologist, and really get a workup, make sure there's not prostate cancer, but probably just that benign growth. And there's ways to manage it and treatments that can be offered for patients so they're sort of not suffering unnecessarily from these symptoms. But frequency of urination or just troubles with stream and flow and can't be in the extreme setting. If the guy can't urinate it, then they may, sort of show up to the ER or need a catheter placed, sort of a tube through the penis to relieve the bladder. And in sort of more extreme scenarios, which we do see for unmanaged or untreated prostate cancer, if you can't get a tube through the penis, they've got to put a tube through the back right into the kidney, a nephrostomy tube. So although it's extreme and kind of caution and warn patients, this is what we see sort of walking in through the hospital with untreated, unmanaged prostate cancer in the most extreme settings, and why we never want to get to that point, why we want to be using our, blood tests and screening mechanisms to avoid those issues. The other important part, I think, is just what's at the bottom of the screen, the last couple of bullet points there. If prostate cancer has spread, it likes to go to the bone, as I mentioned before. And that may be a way, actually, how patients first are diagnosed. If it's already, they again haven't been screening often, or maybe have not regular screening and have lapses, and suddenly we sort of miss that window of opportunity, and where it actually has spread and metastasized, and gone to the bone. And if it's gone to, say, bone in the spine, it may press on the spinal cord, and they may have numbness, paralysis, tingling. They may have some of these kind of symptoms from prostate cancer causing problems in the bone, or fracture if it's in the hip or the femur, or things like that. So, extreme scenarios, but certainly things that we see for untreated, undiagnosed prostate cancer.
And I want to say also, it's important that Dr. DeVille said, not all large prostates happen to be cancer. So you, again, have to take that enlargement. You get your PSA. It may just be a benign enlargement, but it may press on the bladder and urethra, and so you would have trouble starting in your urinary stream, and so some difficulty there. So that's really important.
And so we have kind of touched on this question previously, but can you both talk about the available methods for screening for prostate cancer, and tell us what tests that you recommend that men do to screen for prostate cancer?
Well, getting the physical exam is the one thing. You may or may not get that digital rectal exam. You can also do an ultrasonic test, but getting the PSA is very important. That's the protein that I mentioned that you want to get. And the controversy about PSAs is, what is the normal, particularly what is the normal for African American men? And this is where you get some difficulty. You may, if we were using 4 as one number in the past, and maybe that number didn't change over time, but maybe it started to increase rapidly. And so those are signs that you really want to have a more thorough exam and get other tests. And so I will let Dr. DeVille go into the difficulties of what we look at in terms of normality for that PSA test. And let me just point out one other factor that is very important. We as African Americans need to participate in clinical trials so that we can have data to support what is a normal test for a specific disease. Because again, those normals are made upon the larger number of individuals that participate in a clinical trial. And if we don't have a significant number participating, the numbers that come out may not be applicable to us.
Yes, so just to add, so we're hearing about the PSA blood tests a lot. Um, and I should just say, and I think, it's probably part of the follow-up that we'll talk about this, but, the screening guidelines really talk about PSA, prostate cancer screening starts with the conversation between the patient and the provider about the risks and benefit of pursuing screening. It's really sort of not meant to be just do a PSA test. So I often see from men, kind of ask them, was, prostate being screened? Is this the only PSA value? Do you know if it was being checked in the past? And they say, I don't know. I think it was being checked. Right. So I tell them, if you don't know whether you're being screened for prostate cancer, you weren't being screened appropriately. You really should have an understanding, is prostate cancer being checked for? Really just ask your doctor, right? What are we screening for? What are we checking? So that blood test, the PSA, one things we might hear people say, oh, I hear it's, it's not accurate, or it's a lot of false negative, or these sorts of things. And then really PSA is just a marker, prostate specific antigen, that protein, as we heard about protein from the prostate cell. And so the number that's been, or the range that's been established as normal was sort of 0 to 4. um, and really that number just sort of meant, when do we think the risk is high enough that it's worth now pursuing a biopsy and sampling the prostate to see whether there's cancer in there. But there may be patients who are under 4 and have cancer, and there may be patients who are over 4 and don't have cancer, right? And then 4 is a little bit arbitrary, as Dr. Brown was mentioning, in that you may have, it's particularly age adjusted PSA, where we may allow older men to have a little bit higher PSA, younger men should have a little bit lower. Also, the size of the gland. There's an idea of the PSA density. And so the bigger the gland is, the more PSA you may have. And that, remember, that larger gland we talk about may simply just be that benign enlargement that's not really cancer causing a problem. So we have to not just look at the sort of single value of the PSA, but really what can be most helpful is that PSA trend over time, as Dr. Brown mentioned. And so if you're seeing your doctor on an annual basis, or your urologist or your primary care, and checking that PSA annually, we may see men that, for example, if there's a 2-point increase in a year, that's concerning. If they went from, 1.1 to 3.5, they didn't hit 4, but that's a big jump in a year. We should go investigating and looking into whether that might be cancer. Fortunately, the tests that we now have are much better at picking up, worrisome, true, prostate cancer that can potentially be problematic. Things like applying an MRI and deciding, okay, is there anything concerning? Should we pursue a biopsy? So I say that, and we can talk more about it, but just to men, as, kind of saying, don't necessarily, because again, there may be some fear of like, oh, I'm gonna, what the next test, and I'm worried about the tests and the side effects and the risks and these sorts of things. And there may be multiple options. Don't get ahead of yourself. Let's, one step at a time, evaluate the PSA, see if it's a concern, talk about what test might apply afterwards. So they're not going from 0 to 100, but really, and that's ultimately causing them to not do anything, sort of sitting in fear, that they're kind of, going through that with their doctor. Again, hopefully have a good relationship with their primary urologist to talk through those things.
This slide just graphically just shows what we have been talking about as far as the rectal exam, but I want to jump to the next question. This is the question. So you please have a discussion about, what age should prostate cancer screening start for Black men? Because there have been discussions about the benefits of screening outweighing the risk. And, a few years ago, there was the discussion of now talking about what you said, shared decision making, and then the different organizations, their guidelines conflict. So tell us, when should Black men start screening for prostate cancer?
Well, I think the screening is going to be very specific. You want to have what I call precision therapy. Yes, the guidelines, and there are a number of guidelines, the National Comprehensive Cancer Network, the American Cancer Society, the U.S. Public Service Task Force, a number of them have come up with guidelines, and they are just that, guidelines. So if you have a relationship with your healthcare provider, you know your family history, and we've talked about your risk. And if you are in that medium to high risk category, you may want to start getting a PSA at age 40, 45, whereas many times, say 50 is sort of the number that we generally think that's an older age. As you mature And you know that prostate cancer is a disease. As you get older, your prostate gets larger. And so if you live to be 95, you're really going to have a large prostate more than likely. And so looking at when to start that is a discussion with your healthcare provider, looking at the guidelines as a direction to lead you a little bit, but making it very precise and targeted for you with the shared decision making, that knowing your family history and knowing your symptoms and looking at those risk factors to get you to say maybe starting at 45 is the appropriate age or younger.
Yeah, I definitely agree, and support all that said. There, there's a lot of bodies, and sometimes that can be confusing for patients. The U.S. Preventive Service Task Force is quite late; it's 55 for men without any risk. American Cancer Society talks about age 50. I think, for Black men specifically, the younger ages is what makes the most sense, and usually advocate for starting by age 45. The AUA, American Urological Association, and also the latest guideline, the one I referenced in the in New England Journal, that came from the Prostate Cancer Foundation guidelines for Black men and screening. Advocated for starting between age 40 and 45. But if you can establish a baseline PSA at age 40, and then you can track that over time. And if it's quite low, actually, there are sort of guidance on it, maybe it could even be every 2 years and not necessarily every year, really if it is very, very low. So I think it's important to, start early and then follow the trend over time. Will give more information than sort of starting very late and just having one number and no context. It's kind of harder to know how quickly have things been progressing and changing over time.
So I put in, thank you for that. So
Oh yeah.
I put in the chat the NCCN prostate cancer screening guidelines, the American Cancer Society guidelines, the Prostate Cancer Foundation screening guidelines. And so I also put those on the slides 36, 37, and 38. So you can have all of those guidelines for you to look at and discuss with your primary care doctor. And on slide number 39, I put that slide in that you gave me, Dr. DeVille, because there was a lot of confusion that came out after the 2012 United States Preventive Services Task Force about the guidance about it became less hard and fast about prostate cancer screening, whether to do it, when not to do it. So I wanted to know if you have any thoughts to help clear up any confusion about prostate cancer screening, because a lot of men got the impression that, oh, I don't need to do prostate cancer screening at all.
It had a real impact, and it's very unfortunate. What and I think it still persists. There's still some lingering. Oh, I'm still confused about whether we should be screening or not. And so, in 2012, when the guideline was changed, actually recommend against screening. It wasn't even just have the conversation. It was like against screening. And there were a lot of arguments, there's a lot of debate, literature and media, everyone in societies kind of saying, not following and still advocating. Most of the American Cancer Society, AUA, everyone's sort of still advocating for it. But there's real implications. Insurance companies, et cetera, follow US Preventive Service Task Force. So things may not be covered. When people are following guidelines, they may say, I've been told, and this is what I would hear sort of in the community, and providers like, go places, and they say, oh no, we're not screening for prostate cancer anymore. I mean, these would be places in very urban, you got Black population, high risk, not normal risk. You really should still be screening. And that's what the data shows, and some of my colleagues here, Tim Rebick and Brandon Mahal and such, I think we don't have the color coding, but on the right, sort of you could see that screening decline in Black men, those who are most vulnerable, underserved, those were the populations that were no longer sort of less likely to get screened. And those, who had more access, more means, continued to kind of get screened in that period. So unfortunately, we saw and still see a lot of men presenting with later stage disease in that gap because of it. So it's quite unfortunate. And then in 2018 was reversed back to that shared decision-making conversation around, should we screen or not screen, making sure people are aware and pursuing the PSA. So unfortunately, yeah, it's still kind of some of that a confusion or controversy still persists. And I think people, and also leads to the confusion around like, well, I heard that, screening's not good, or, just a lot of confusion around that. Hopefully we can clear that out and, through these conversations. So there really is demonstrated documented benefit to checking PSA early, catching prostate cancer early, and our outcomes for prostate cancer are always better when we treat early. And now our treatment options, our diagnostic options, our treatment options are getting better and better. And so that we can balance, because part of that era and why that guideline kind of changed back then was this concern for sort of overdiagnosis and overtreatment. And now we know there are certain types of prostate cancer that we don't need to treat right away, that we can, if it's very unaggressive, I think we'll talk about up soon, the Gleason 6 prostate cancer, that's cancer that we can just monitor and keep an eye on and do what's called active surveillance. So we don't need to rush to treatment and potentially cause harm with our treatments, that we can take a more measured approach. And so, again, sort of just telling men, hey, again, we're going to kind of work through this slowly, and don't worry, don't avoid finding out about cancer because you're worried about everything that might come after it.
And Dr. Brown, what are your thoughts about this prostate cancer screening conundrum that was started in 2012?
It reminds me of the conundrum we have with breast cancer screening and getting a mammogram, and how the organizations that put out the guidelines have caused confusion whether you should get a mammogram once a year or every 2 years, and what Medicare will pay for, because you're getting it as you get older. This is the same kind of thing. Both prostate cancer and breast cancer are hormonally related diseases. It happens that Blacks tend to have a higher incidence in both of these cases. And again, when we come up with guidelines, I always like to say, have that conversation with your trusted provider and look at the data. Look at the science of how many people were put into that guidelines when they made that decision, and look at your own family history and personal history, and come up with a decision that makes good sense for you. And so again, I would not go along with saying you should not get screened with prostate cancer, get a PSA, because again, getting Black males to medical care in general is difficult. And so when you have a situation to say, oh, maybe you should do away with it altogether, that gives them the good ammunition to say, well, I'm following guidelines, and so I don't need this anymore. Also, I think it's important for us to know that the guidelines, as Dr. DeVille said earlier, this is an indication of whether your insurance is going to pay for it. So you have to look at the economics of this. And if you don't have insurance, you have an insurance company that say, I'm going to deny this because the guideline says it's not important. So you again have to work with your provider to make sure that this is recommended and that you're going to continue to get it. I'm not one to follow the U.S. Public Service Task Force. One, as an aside, I don't know how many of us are sitting on that particular task.
Yeah. Yeah. Can I just add one comment too, just to go back a little bit? I think we often talk about when to start screening, and then what often doesn't get talked much about, and not until recently with the diagnosis of President Biden kind of brought to light, is, when do we stop screening and should we stop screening? And most of those guidelines, U.S. Preventive Service Task Force being an example, said at age 70, you could stop screening. And really, again, it should be it really should be at age 70, one should have a conversation around, like, should we continue screening? Of course, weighing the person's overall health status, their life expectancy, other medical issues, and kind of, have that explicit conversation. Again, many of the men I see who might have been in a situation similar to President Biden didn't know whether their PSA was still being checked or not. And I shouldn't sort of reference his case so much. They disclosed later that he had not he had stopped screening. They had stopped screening, and perhaps that was their decision, and a conversation didn't happen appropriately. I think many of the men that I see who are 75, 80, um, and are diagnosed often with aggressive prostate cancer, and we're sort of looking back and trying to figure out, was the PSA still being checked, and it wasn't, or maybe not consistently. And then they're presenting with symptoms, or finally someone sort of they see a new doctor and someone checks it and the PSA level is very high. So I think, we often focus up front when to start. We're saying by age 40, but once we reach age 70, we shouldn't just stop. We should make sure that the men in our lives who are that age know whether they're still having a PSA checked annually with their primary care doctor, and not just stopping it, but they're at least having awareness and having those conversations if they should continue screening or not.
Yes, and as we are living a little bit longer, not that much, I think it's important to look at the person's overall health status, the comorbid conditions that are along with that before you make a decision, because you're taking a number, and that controversy certainly goes over to breast cancer. And at some point, they were saying maybe you should stop at 75 for doing mammograms. And again, you're finding that women are living longer and you're getting breast cancer. And so the age to stop, and perhaps we need to look at geriatric care and geriatric studies in a clinical format to make sure that we have data to support that, because there's just not data out there for longer continuing the screening, or when do you cut it off?
So we've talked about a lot about screening, and so I want to, in the time that we have left, I want to get to now talking about once prostate cancer is diagnosed, men will start hearing about prostate cancer grade and the Gleason score and getting a biopsy. So I have this video before you guys start talking about that. This is just a schematic. Tasmin, if you could hit that button and see if it will play of how a prostate biopsy is done. A simple version of multiple ways of how a prostate biopsy is done. But the question, as you guys can get started, is once prostate cancer is diagnosed with, however, that tissue is taken from the prostate, what are the stages of prostate cancer and how is treatment determined from that? And so I did not make a slide of those different stages because it was way too complicated for me to try and put on a slide for people to understand. So if you could verbally explain when men start to hear about this scoring and in what stage their prostate cancer is in once they are diagnosed.
Yes, well, Dr. DeVille, once you have the PSA and you have a biopsy, they determine a Gleason score by looking at the path report and coming up with a number. What that number means has a lot of implications for what's the next step in terms of treatment.
Yeah, exactly. So we would look at that information. So the PSA, the Gleason score, and really for prostate cancer, I'm kind of explaining to patients we use what's called a risk stratification that takes into account the PSA, so the marker in the blood, the Gleason score, the score that's been derived from the tissue, and then what we call this tumor stage. whether we see signs of cancer moving beyond the prostate or could feel anything abnormal when we check the prostate. And then we're going to classify patients into these categories of low, intermediate, or high risk. And this is if it hasn't spread, right? And you'll do imaging studies often to make sure that it's not spread distantly. If it has spread distantly, that patient would go off to see a medical oncologist, usually like Dr. Brown, and think about systemic therapies, treatments that can go through their whole system since it has spread distantly. But if it's localized, and the majority of patients would have their cancer, that diagnosis, we said like 90% are diagnosed where it's still localized. We would stratify the cancer and then figure out what's the appropriate management. If they're in the low risk group, so that's usually a PSA less than 10 and a Gleason score less than 6, those patients are the ones who I mentioned before can actually be offered just a monitoring strategy, active surveillance. And that surveillance strategy is usually something like serial PSAs over time. So this is usually done under the care of a urologist. It might be something like a PSA every year, or PSA every 6 months, and a MRI and biopsy every year, depending on PSA changes and those MRI changes. And so that's what surveillance look like. And then if they catch sort of prostate cancer showing signs of becoming more aggressive or progressing, for example, on the biopsy, say a year or 2 years later, now it's a Gleason score of 7 instead of a 6, those would be the triggers now to move on to treatment instead of just monitoring. So the reason we can do that is because Gleason 6 prostate cancer is a cancer that doesn't spread. So just to break that down a little bit in terms of the score, because we hear a lot about the Gleason score and it's important to understand, I tell patients when the biopsy tissue, those cells are, collected from the prostate, the pathologist is going to look under the microscope. And if they see cancer, one is it show each little piece of tissue show cancer. Yes or no. If it's yes, they're going to score it 3, 4, or 5. 3 are the least aggressive appearing cells, 4 intermediate, and 5 are the most aggressive that have the potential to spread. And because you often have more than one pattern in the area, they're going to score it twice. And that's why you see the score as the sum of two numbers. And you'll see people saying things like Gleason 3 plus 3 equals 6, or Gleason 3 plus 4 equals 7. The number that you have first is what you see more of. So in principle, Gleason 3 plus 3 equals 6 is the cancer that's not going to spread or has low risk for metastatic potential, and those are the patients that are going to be monitored. I should also add there are now additional studies that we can do, evolving, biomarkers, prognostic indicators, genomic studies. So there's further analysis we can do of the tissue specimen that are better. This is the era of personalized medicine and precision medicine, as Dr. Brown mentioned before, that can really help us hone in. And so a genomic study, for example, will analyze a panel of genes associated with risk of spread. And so I'll tell the patient, not only do we have now your PSA, your Gleason score, we also have a genomic risk score that's predicting your tumor profile has a risk of spread at 5 and 10 years of X%, Y%, and risk of death at 15 years of this percent. Those things also help us decide, is monitoring a good strategy, sort of confirm monitoring, no treatment's a good strategy, or no, hey, maybe we should move on to treatment sooner. The next risk group category is the intermediate risk. So that corresponds to the PSA between 10 and 20 or a Gleason score of 7. Those are the patients that we still have very high cure rates. The risk of cure, 85 to 90% of patients are cured with treatments like surgery or radiation, but there's a 10 to 15% risk of progression. And so those are, again, we don't want patients to risk that because those are the ones who ultimately have spread or death from prostate cancer. So those are the patients that are going to be offered surgery or radiation. And then that high risk group may be patients that have a PSA above 20, or a Gleason score between 8 and 10. And those are the ones that have the most metastatic potential. And if they have surgery, they may need additional therapies afterwards, like radiation and hormonal therapy. Or if they have radiation, we're often not doing radiation by itself, but we're adding things like we call hormonal therapy or temporary suppression of the testosterone that helps to make the radiation more effective, weaken and starve the cancer cells from the testosterone it's feeding off of. And so treatments become more comprehensive as the cancer is becoming more aggressive. And there are often treatments, as we kind of mentioned before, or alluded to, that can have a significant impact on quality of life, sexual function. And that's kind of the tough part for men. Although we can have very good outcomes with our treatments for prostate cancer and very high cure rates, it may come with some short-term and long-term consequences from the treatment. So I'll pause there because I know we have more along those lines, and certainly Dr. Brown, feel free to add anything. Yeah.
I want to add one piece. Can you talk about when you add the PET scan to the treatment armamentarium.
Yeah, no, and that's an important point. I kind of skipped. So when we get to our screening, diagnosis, and analysis of the Gleason score, so when we do that risk group stratification, that also determines how much more imaging or how much more workup do we need for the patient. And historically, it would be things like getting a CAT scan or a bone scan. And so these are studied the nuclear medicine scan for the bone, just injects a tracer and it would look at the bones and kind of light up in areas of concern. But if there was anything obvious, and then the CAT scan looking for a similarly spread to bone or other organs or lymph node involvement. About 3 or 4 years ago, maybe now, the advanced PET scan tracers were FDA approved. One of them actually was developed at Hopkins, and so we've had access to it since 2015, actually, or sooner, even doing studies with it. These PET tracers are now kind of the standard of care. They're more accurate at picking up small areas of spread, so they can sort of light up within the prostate, can show activity cancer within the prostate, and then are more sensitive to picking up small areas of spread beyond the prostate, so lymph nodes or spread to bone. And so usually in terms of guidelines, they talk about anyone in the intermediate risk or the high risk group are the ones where we can get a PET scan. That's a PSMA, prostate specific membrane antigen PET scan, PET CT. So we can get that scan for anyone in those risk groups looking for distant spread. And I always warn and caution men, because these are things I hear often. They say, well, the scan didn't show anything. Just because it didn't show anything doesn't mean it's not there. There's always a threshold, a limitation to detection. And the smallest little ditzel we can see on a scan concerning for cancer is usually about 3 millimeters or so, 2 to 3 millimeters. That already has a billion cells sitting there. So we can't see 1 million, we can't see 100 million, even if it's spread. So when we think about our treatments, we kind of counsel patients, we're going to think about the cancer you see and the cancer you don't see. And so, for example, for treating the prostate with radiation in the high risk group, we often will include the adjacent lymph nodes, or if that patient's having surgery, they're having a lymph node dissection. Even though you didn't see any obvious lymph nodes on the scan, there's maybe 10, 12, 15% risk that microscopically cancer cells have made it to those areas. And so you're still going to treat or target those areas when you're sort of managing the cancer. But the imaging is a very good point because, again, we have evolved over time. We're getting better at picking up those small areas of spread beyond the prostate, and that helps us tailor our treatments to them.
And so you have on our next slide 41, you both have began answering the next question about just talking about the different treatment options for prostate cancer. And so we do have a question that even gets to that question as well. How common are urinary incontinence and erectile dysfunction depending on the treatment? And what treatments or therapies help men recover sexual function after treatment?
Well, surgery and radiation will give you issues with urinary incontinence. And so I think from a surgical standpoint, you have to have very delicate surgery so that you're not damaging your nerves. But again, the urinary incontinence tend to be a more common side effect of therapy. And I say a side effect. And certainly some of that comes with radiation as well. And there's various types of radiation therapy and how that plays into whether it damages any of those nerve endings that's there. But since I usually have the chemotherapy, we don't give you that. But again, you're going to have some weakness and early fatigue that will go along with the chemotherapy. And depending upon which one you get, you may have some other damages as a result of the chemo. But we've moved into immunotherapy. It's a little bit better, but I will let the radiation oncologist talk about the side effects of radiation. But we usually work in combination. So it's a team approach in terms of care.
Yeah, I agree. I think that's a great point. The multidisciplinary management is key, and physicians partnering and working together in a collaborative way to the benefit of the patient. And so hopefully the patients themselves are experiencing that, and they're not go out and seek it as well. It really shouldn't be, you feel that you're sort of pitted against each other. The surgeon said this, the radiation oncologist said this, the medical oncologist said this. How I explain it to patients is often, we may not end this conversation by saying this one treatment is better for you. You may have a menu, just as is listed on the screen here. You may have a menu of options, and really it's about us kind of going through and seeing what's appropriate for you and what's not. And then within your own value system, preferences, that sort of thing, what might suit you best, and perhaps we can kind of rank them that way. Patients would often ask me, I like to joke when I was younger, now they just ask me, what would you do? When I was younger, they would say, what would you do for your father? And I like to say, what my father would do is different than what my uncle would do in the exact same situation, right? So it's not about me imposing on you. It's really just understanding where you're coming from. And for one patient, um, well, just to break this down a little bit, kind of in kind of more of an example, I often tell men over 70, they're often steered towards radiation. Under 60, they're steered towards 70, towards surgery. Sorry. So over 70 radiation, under 60 surgery, and 60 to 70 can go either way depending on their overall health status and personal preferences and those sorts of things. And actually, men under 60 can have radiation, and men over 70 can have surgery, but just kind of in sort of general thinking and kind of general age ranges. And the reasons are, over age 70, risks from surgery might increase. The operative risks, wound healing, anesthesia, all these kind of factors that we don't have with radiation. And then on the flip side, in terms of, age, young men are going to recover from surgery well. The surgeon says, hey, this is a great surgical candidate. He's 50 years old. He's probably going to heal well. He's going to preserve those neurovascular bundles. And so we don't argue with that. And one of the things with radiation, it may cause a risk for inducing or creating a cancer 5, 10, 20 years down the road. That might be more of a concern for a 50-year-old than a 75-year-old. And so there may be things that, again, help us kind of rank or steer patients in a certain direction based on the individual in front of you, and sort of how, where we're kind of staging their cancer, what are the appropriate treatments, their own history, how big is their prostate, what kind of symptoms do they have, are there things that help us triage and understand whether this patient is more suitable for surgery or radiation. I think in the fourth bullet point there, so our standard treatments are surgery or radiation, where we have the both best outcomes for. The sort of bottom 10, list of bullet points are the systemic therapies that often are delivered by the medical oncologist, but may also sometimes a radiation oncologist urologist may do hormonal therapy, for example, things like that. Um, those are usually, at least for patients that are early stage and curative, they're often just sort of an adjunct or in combination, and probably wouldn't be a solo treatment if we're talking about patients who are potentially curative and their cancer hasn't spread. The fourth bullet point there, in terms of focal therapies and ablative therapies, there's very limited data comparing them, studies comparing them to surgery and radiation. Many places, and at Hopkins, for example, they'd be quite selective, the urologists, in terms of who we evaluate and how we're studying these therapies to understand whether the outcomes are just as good for patients as surgery or radiation. So I think it's just a word of caution that if you are considering those alternative therapies, they're usually not good for men with very aggressive disease. So in the high risk, Gleason 8 to 10, those patients have aggressive disease, they need a lot of therapy, that those are probably not suitable for them. They're more on the end of that sort of low and intermediate risk, less aggressive. And particularly for focal therapy, it's for men who have very limited disease, maybe only one spot on their MRI. It's the only spot that showed up on the biopsy. And they're interested in pursuing, a potentially kind of less aggressive, approach, and seeing that if that can have benefit. And so I think we're learning more about those over time, but again, we don't have data that those are just as good as surgery and radiation, and that's just a word of caution. Again, if you're considering those things, make sure you're going to, getting second opinions and third opinions, and getting high quality opinions before you make your decision about whether to pursue them or not.
And just a question in reference to, I don't know whether they call them rectal beads, but it's a type of radiation internally, and also with radionuclide insertion. How about those two for
Yeah.
usually more advanced disease?
Yeah, so on the radiation side, we can do external radiation like X-ray treatment or with particle therapies like proton therapy that we do as well. But really, that's kind of like when a patient has an X-ray scan, you lie on the table, you don't feel anything, see anything, you're immobilized, and we target it at the prostate, and you kind of get off the table, go home, go to work, go to X-ray, continue about your business. And usually that's over a prolonged course of several weeks. It might be 5.5 weeks nowadays is the most common regimen, but it can be as fast as 5 treatments every other day in terms of stereotactic radiation or cyberknife. People have heard of sometimes a radiosurgery. There is internal radiation where we can actually put the radiation inside the body, and that can be done with it's called brachytherapy or prostate seed implant is common, and people have heard of that. Can nowadays be done with catheters where the patient doesn't go home with the seeds in their prostate that stay forever and decay over time and kind of kill the prostate within the gland. Now with the catheters, it's brought a radiation source is brought into the room, exposes the prostate. You pull that out, pull the catheters out, patient goes home without any radiation in their body. So there are a variety of radiation treatments, external and internal. The internal ones are still very good. It's just a matter of is what the conversation I was getting to beforehand, where you're sort of talking to the patient and seeing, is it someone who might be interested in that type of approach? It's somewhat invasive. It's going to require some, radiation safety precaution and these sorts of things. Or would they just prefer as kind of an outpatient, kind of non-invasive approach in terms of deciding for the radiation? But they can be done in combination too. Sometimes if people have more advanced disease, you may be doing both. And you mentioned also the radiopharmaceutical therapy there that we see a lot of commercials for nowadays. The lutetium, or it's known as Pluvicto, and there was another one, radium-223 Xofigo. Sometimes I call those liquid radiation to patients. That's actually an IV infusion. Those are for patients with metastatic prostate cancer that spread throughout their body. And it's a form of systemic therapy that's going to go through their whole system. It takes that PSMA scan that I mentioned before, and it tags a form of radiation to it. So when you inject that tracer now, it's going, and it's not just being done to image the cancer, but you're actually delivering radiation to those areas. And that's an infusion that's done once every 6 weeks or once every 4 weeks for a few cycles and can prolong survival. And it's now being applied and studied earlier and earlier, and even for men who don't have necessarily widespread cancer, but maybe limited sites of spread, or we're studying it now for men who are in that high risk group without visible sites. So definitely we're learning, and treatment is evolving even year to year in terms of the survival benefits and our ability to stay ahead of the cancer.
So thank you. We are at our time. So thank you very much for all of the information that you have given us. We have learned about screening, taking away the fear about screening for prostate cancer. We've talked about diagnosing cancer and gotten into the details about prostate cancer treatment and all of the options and emerging options for prostate cancer treatment. So thank you, Dr. Brown and Dr. DeVille, for taking your time to explain this to the men and the women in the audience. And thank you, audience, for joining us. The resources and slides and links will be sent to you by email in our post webinar email. So thank you for joining Alpha Kappa Alpha Sorority Incorporated, the North Atlantic region, as we talk about prostate cancer screening, what we all need to know. And everyone, have a good evening. Thank you.
Thank you.
Thank you.
Thank you.
Good night, everyone.